2, 1.
Good afternoon, and welcome back to the final hours of the 2020 Hypopara Virtual Conference. I have the pleasure of introducing Dr. Kimberly Liang, who is going to speak to us about building experiences reading labs. Dr. Kimberly Liang is a practicing rheumatologist as well as a hypopara patient since 2009, which means she has personally vested in this. She received her medical degree from Jefferson Medical College in Philadelphia, Pennsylvania in 2002. She did then all of her postgraduate medical training, including internal medicine residency and rheumatology fellowship at the Mayo Clinic in Rochester, Minnesota, graduating in 2008. Following that, she joined the University of Pittsburgh Medical Center as an assistant professor of medicine in the Division of Rheumatology and Clinical Immunology in Pittsburgh, Pennsylvania. She has completed a master's degree in clinical research through the University of Pennsylvania Institute of Clinical Research Education in 2016 and has been involved in clinical research regarding rheumatoid arthritis, lupus, and vasculitis. She has contributed frequently to previous newsletters for the Hypopara Association since 2013, and now in person, Dr. Kimberly Liang.
Hi everyone, thanks for having me again. It's so nice to be with you all virtually. So today I was going to talk a little bit about my own experience living with hypopara, as well as, interpreting lab results, kind of what you should be asking for and how to interpret them. So I have no financial conflicts of interest, and as was mentioned in the intro, I'm a physician, but not an endocrinologist. I'm a rheumatologist. As Loretta mentioned, I am a hypopara patient myself since December 2009. I'm a post-surgical patient. And so the experiences I'll be talking about are sort of mine both from a physician and patient perspective, but mostly from a patient perspective. The lab work knowledge that I'll be telling you about today is obviously from my own knowledge as a physician. So it's important to realize that every patient's case is unique, and every physician's practice style is different. So even regardless of what I tell you here as sort of guidelines, so-called, you should still work closely with your own individual physician for your own lab testing and care. So my journey started when I was first diagnosed with a 1.3 centimeter left thyroid nodule by a neck ultrasound in September 2009. That was done because I was feeling like my neck was getting a little thicker. I had some strange hives and some other symptoms. And that led to basically a fine needle aspiration biopsy in late October 2009. On the biopsy result, it actually came back as papillary thyroid carcinoma. It wasn't even equivocal as so many of these FNAs often are. So I knew that I had PTC. I ended up having to wait until December 14th, 2009 to get my surgery, a total thyroidectomy with central compartment lymph node dissection. Those, I must say, were probably the most harrowing weeks of my entire life, being riddled with anxiety about the surgery. Ironically, I was most concerned about the risk of going hoarse from recurrent laryngeal nerve damage. I didn't even hardly give a thought to the parathyroids because they said it would just be taking some calcium if that happened. So I didn't think that would be anything major, So anyways, immediately post-op, I experienced severe numbness and tingling in both arms and feet. It was very scary. I had just made it to my room. I was suddenly experiencing this. It was also perioral numbness and tingling. I told the nurse, she gave me 4 Tums to chew immediately, and they came and drew my blood. And then later that night, they just said, oh, the calcium came back okay. It was 8.7, But later I kind of looked back and realized that my pre-op calcium was 9.5. So obviously it was already starting to drop pretty precipitously, causing the symptoms. So over the next 8 weeks post-op, my serum calcium continued to drop. You can see the trend to 8.1, then 7.7 in January and 7.4 by February. Of course, by that time I was, you know, very symptomatic. I couldn't even walk on rounds without my feet cramping up. I couldn't stoop down to examine patients' joints without, you know, having my own feet go numb, etc. And I had serial serum PTH levels all drawn. In February, all of them were less than 3, basically undetectable. My endocrinologist diagnosed me with post-surgical hypopara. Ironically, my endosurgeon, my 3-month post-op visit in March 2010, was very cavalier about it and kind of acted like, well, this is just a temporary thing, because a lot of times post-op, of course, there is transient hypopara. She was convinced that this would not be a permanent case. You know, she was one of the world endosurgeons that I had gone to, but of course that didn't turn out to be the case. So I had initial difficulties controlling my calcium levels on calcium carbonate supplements alone. I actually was not started on calcitriol until July 2010, which was 6+ months after my surgery. I think they were thinking, well, you know, again, maybe seeing if my parathyroid function would return on its own. Actually, in June, I think it was June 2010, I had gone to Hawaii. I had no clue at all about what this disease could or did do to my muscle strength and my exercise tolerance. I hiked up one of the tall, you know, hiking things in Hawaii, and I completely crashed after that. Could not enjoy the rest of the vacation at all. I couldn't even move. I couldn't even walk in a grocery store. So things went not so well, basically continued on until, you know, April 2011. Then, you know, I had the fortune of kind of getting in touch with Dr. Gaffney at the NIH. I was getting some information about some studies she was doing at the time, but she actually gave me some advice about, you know, splitting my calcium doses into less tabs more times a day instead of so many tabs all at once, just twice a day. And of course that did help me. You know, obviously you can only absorb 500 to 600 milligrams of calcium at a time. So doing that really helped. And then finally in June 2015, when Natpara came on the market, I did get started on it pretty quickly. It did give me good benefit. I felt like within the first day that like 30 pounds was lifted off my legs. My muscle strength improved quite a bit, but still, of course, not to pre-surgical levels. My dose was gradually increased from 50 to 75 in 2015, later in 2015, and then from 75 to 100 in October 2017. And then, unfortunately, as we all know, in September 2019, Natpara was withdrawn from the market due to that rubber particulate issue. And so, luckily, I was able to get onto Forteo. I do split my Forteo into 3 times a day dosing in order for it to work pretty much as effectively, I think, as the 100 of Natpara did. So my hypopara symptoms include the fatigue, muscle twitching, numbness, tingling in both the extremities and perioral. And for me, I always describe it as like, it feels like a snowflake is on my nose, or like teeth vibration sensation. That's kind of how I feel it, but I know that that's the perioral. Paresthesias, basically muscle cramps and spasms. Sometimes they can be very painful and wake me up from sleep. You know, gut irritability, which again can be very severe, debilitating at times. Muscle fatigability and exercise intolerance to me is one of the worst symptoms that I have from the hypopara. It's very limiting. I mean, I was never really like a true athlete, but even just compared to, of course, pre-op levels of exercise ability, it's a hugely worse situation. Subjective muscle weakness, meaning, of course, if you were to test my muscles, and probably most people here, it wouldn't be objectively weak on muscle testing, but you just feel weak kind of a lot of times. Neuropathic pains, where I get like the hot poker here and there, the pins and needles, and intermittent mood irritability, swings, anxiety, sometimes tremor even at night. I'm not sure if that's hypopara related, but I think it probably is. So I've identified a number of stressors for myself. Of course, the physical activity, like I said, especially if you do too many days in a row, like it's not like you can't do it, but then if you do too much activity too many days in a row, or too long time of physical activity, that seemed to make things worse. Menstrual cycles are a huge one. Illnesses, if you lose sleep, that's often a huge issue for me. And then also travel or change in time zones are difficult. My main complication that I've had from it is kidney stones. I have had 2 kidney stones in summer 2018, and then just recently I also passed at least 1, if not 2, kidney stones in July 2020. It was very, very painful, really a horrible experience. So that's sort of my story till now. I'll jump gears now into the lab tests and kind of, why we need a lot of different lab tests all the time, what to look for, how to read them, sort of how to discuss with your doctor, and then some other things that you should think about maybe for sort of fatigue or muscle weakness type symptoms. So why is calcium and lab monitoring so important in hypopara? Normally, the parathyroid hormone functions to keep the blood or serum calcium and phosphorus levels steady constantly, like minute to minute, like second to second throughout the day. And a lack of PTH causes the serum calcium to drop and the serum phosphorus level to increase. So, and as others have mentioned during this conference, if the calcium by phosphate product goes over 55, like high levels basically, that increases the risk of soft tissue calcifications, also called calcinosis. And then if the 24-hour urine calcium goes high, like usually something like over 300 milligrams per 24 hours, that causes an increased risk of kidney stones and kidney failure. The kidney failure is from like nephrocalcinosis, which is tiny calcium deposits within the kidney parenchyma itself. If the calcium drops dangerously low, and I would think anything less than about 7.5 corrected, certainly less than 7, would be considered emergency. You would be at increased risk of true tetany, where you can't come out of a severe cramp, seizures, arrhythmias, again, potentially life-threatening, should go to the ER. So, and like we've mentioned, like calcium levels in hypopara patients can drop quickly, kind of drop suddenly, like out of the blue, it seems sometimes. And I mentioned some of the triggers or stressors that contribute to my fluctuating levels. I think, everyone might be a little different, but you should realize that can happen. Dietary changes over time can also affect the total daily calcium consumption and thereby affect your levels. 24-hour urinary calcium levels actually can also change over time. And then phosphate levels being high can maybe requires a change in your diet to reduce phosphate-rich foods in the diet. Another thing is other electrolytes. So it's not just all about calcium. I mean, potassium and magnesium are also important for calcium absorption. And low potassium, also called hypokalemia, and low magnesium, hypomagnesemia, can also cause muscle cramps and weakness, can actually really mimic a lot of the hypocalcemia symptoms. Vitamin D is also a very important test. It's important for calcium absorption, and it's not only important for bone, but also for immune health. I think people have probably seen that keeping vitamin D levels higher even seems to be associated with less risk of COVID. There's a lot of controversial aspects of vitamin D in general, and I'll sort of talk a little bit about that later. And then also, calcium levels don't always correlate with symptoms. So it's really important when you're having symptoms to be checking all these different tests, because if the calcium level really isn't low when you feel extremely low, well, for one, you need to see the trend, what's going on with the trend, and then if there's no trend for going up or down with it, then maybe you need additional tests or workup for other things. So just a little bit about for post-surgical hypopara. Early, like within the first 3 months, like I mentioned, there is a possible return of parathyroid function. So you need really frequent checks to ensure that it's safe to wean down on the Tums or other calcium supplement. A lot of times they'll just spell out this taper, but if you're within that first 3 months post-op and they're just spelling out a wean without regular calcium checks, that can be very dangerous in case you're actually a longer-term hypopara. And then you also need to watch for hypercalcemia, because you may be taking all these supplements and it may cause your calcium to go high. Now, late or long-term permanent, most of the people here, I would imagine, if you're post-surgical, that's after 6 to 12 months. That's when you sort of declared as a, so-called permanent or long-term hypopara. You need to have regular checks to ensure that no dose changes are needed in your calcium supplements, calcitriol, or other medications. You also need 24-hour urine calcium monitoring to reduce the long-term risk of kidney damage. So what lab tests should you ask for or be, checking to make sure that your doctor has ordered? I would say, of course, first and foremost, serum calcium and albumin, phosphorus, creatinine, which is a kidney function marker, the parathyroid hormone level, PTH, especially if you're in that for 6 months post-op. And, in terms of making diagnosis of the condition. Ionized calcium sometimes can be very helpful. The potassium, magnesium, vitamin D we mentioned. For vitamin D, when we talk about that, we're talking about usually the 25-hydroxy vitamin D. That's so-called parent vitamin D or regular vitamin D, as I call it. The activated vitamin D is 125-dihydroxy vitamin D, and that is not routinely measured on a, quote, vitamin D assay, the usual vitamin D assay. But in some circumstances, that might be helpful to check as well. The BUN, if the creatinine is high, that can help with assessing kidney function, and then sodium sometimes as well. For the urine, it's important to check the 24-hour urine calcium and creatinine. That usually comes as a, quote, 24-hour urine calcium battery. And then if you have a history of kidney stones, or, if your urine calcium is high and you're wondering what your risk is of that, also doing urine supersaturation analysis studies, also called litholink, that is very important. A general urinalysis, and then if you have kidney dysfunction already, like say you already have elevated creatinine, then a urine protein creatinine ratio or a 24-hour urine protein is also important. So the different monitoring intervals is going to be different for each patient, and then also depending on the test. General suggestions that I would say for within the first 3 months post-op, you really should be getting checks at least every 1 to 2 weeks, especially the calcium and albumin, the PTH as well, because if the PTH is trending, down or up relative to the calcium, you can kind of see what's going on. Normally, if the calcium is low, the PTH should actually be stimulated to be high, if anything. If you're seeing that low calcium and the low PTH, that's kind of how people make the diagnosis, of course, of hypopara. And then also to check the potassium, magnesium, and vitamin D. If you're long-term or permanent, it's really when you make med adjustments, then you're going to need to get those levels, the calcium, albumin, phosphorus, creatinine checked within, after a week or certainly within a couple of weeks. Usually, I think it's going to be, monthly or so until you feel that you're on a stable, quote, drug regimen. Once you're stable, then I'd say at least twice a year, probably more like every 3 to 6 months, something like that, if you're very stable. It shouldn't be less than that in terms of, like if someone is, quote, stable, checking calcium only once a year is still too little because this condition is always changing. If the symptoms and labs don't correlate, then you should consider checking ionized calcium as well. And, I think I mentioned the other electrolytes too. So in general, for the urine, I would check a 24-hour urine calcium once the hypopara diagnosis is established at 3 to 6 months post-op. If things are not looking like you were only transient, then you should be getting a 24-hour urine calcium early on. And then if you're long-term, that 24-hour urine calcium probably every 3 to 6 months for the first 1 or 2 years until that is stable. If your 24-hour urine calcium is really stable, that could probably go to yearly. But, at least for me, that never has been so stable that it's not high. If it's high, you probably need to be doing at least every 6 months. In some states, a basic metabolic panel or BMP can simplify your orders in terms of asking the doc for, if you ask for a BMP, that's going to include a sodium, potassium chloride, bicarbonate, BUN, creatinine, and glucose. Note that it does not include the magnesium and phosphate, so those would have to be ordered separately. Vitamin D levels also should be monitored. Now, these don't change that frequently, so you shouldn't really expect to get that checked more than every 6 to 12 weeks. It takes a little while for vitamin D levels to change. And then I think I mentioned how, just realize that calcium levels fluctuate throughout every day, actually. When should you get your labs checked? So, ideally, you should check them in the morning before supplements, but especially for me, personally, that's very impractical. Really, it's the consistency and the timing of the labs is key. So if you get it checked, say, after your supplements, then sort of always do it that same way so that you can get a sense the next time you check it, if something has changed. Otherwise, you'll be comparing apples to oranges between lab checks. PTH levels in the immediate post-op period, I think, can be useful. There's actually been some studies that suggest that people who have low but detectable PTH levels actually have a higher rate of parathyroid recovery within the first year compared to people who have completely undetectable, as I did. Also, following PTH levels during calcium and supplement weaning is extremely important, I think, because that's the only way to really know if you're staying like a permanent hypopara patient or not. So just a little bit about reading these and interpreting. So the albumin correction for calcium binding relationship with albumin is extremely important because, you know, hardly anyone's serum albumin stays right around 4.0. I mean, there are always some patients where it does, but if your albumin level is either higher or lower than albumin of 4.0, then your corrected calcium is going to be a little different than what it's just measured out as. So the equation is that you take the corrected calcium equals 0.8 times the normal albumin minus the patient's serum albumin, and then plus whatever the serum calcium is reported as. And the normal albumin is defined as 4.0. So if your albumin level is greater than 4.0, then your corrected calcium is going to actually be lower than it appears. And if your albumin level is less than 4.0, then your corrected calcium is actually higher than it appears. And this is really important to be correcting for this, whether or not your albumin is higher or lower than 4.0. I think a lot of people ask, and it seems like some doctors tell them, oh, it only needs correction if the albumin is less than 4. It's not. I mean, you need to correct it whether it's above or below 4.0. So as you can see in these examples, like if your albumin level is 4.5 and your calcium says 8.9, then your corrected calcium is actually 8.5, which, you know, according to, say, this reference range that I was using for this example, was mildly low, whereas 8.9 made it look like it was normal, like it wouldn't be flagged as being abnormal. But really, if you do the correction, it was mildly low. The quote example was actually my own labs on a real lab test. Example 2, you know, if the patient's albumin was 4.5 and your calcium is 8.5, then when you plug that into the equation, then you get a corrected calcium 8.9. So then that's actually much higher than it appears. This is really important for pregnant patients with hypopara, okay? So when you're pregnant, it's normal for your albumin to decrease quite significantly, especially later in the stages of pregnancy. So then as people go along later in their pregnancy, the serum calcium looks like, oh my gosh, it's dropping really low, like low 8s, high 7s. But if you correct it for an albumin of 2 point something or low 3s, a lot of times it's actually much higher than it appears. So you may be thinking, okay, this is getting really complicated, and you know, you don't have time to do this every time. So the easier way is just Google calcium albumin correction calculator, and you can find an easy to use calculator such as this. Another one I like, I think it's called MedCalc. You can just easily plug it in, and if they say normal albumin, then just plug in 4.0. So then people ask also about the ionized calcium. So ionized calcium really doesn't require a correction factor. So it really just measures what is truly available for the tissue, like free calcium available to the tissues and not bound to any proteins. So I kind of like it. I mean, in this example, which was mine, where my corrected calcium was actually mildly low at 8.5, my ionized calcium was actually low. You know, I mean, you can see that on the reference range that it was low. And to me, ionized calcium was always correlated more with my symptoms than even albumin corrected calcium. However, the reason that sometimes docs don't order the ionized calcium as readily is because it does require special handling, and it's not possible at all outpatient labs. It is more expensive. It's sort of reserved for in-hospital settings, especially intensive care units. It's kind of like a stat lab. It gets reported out, you know, really quick. It needs to be, you know, handled and then processed really quickly. And then it can vary slightly for adults versus children too. However, I have found that, you know, if I go to a Quest lab, as long as I go before, you know, the last half hour, it's been pretty reliable actually. And then same with my own hospital lab that I go to. So in hypopara, look to see if your labs show these potential expected abnormalities. You should have a low corrected calcium and or ionized calcium, a high or high normal phosphate level, a low or even low normal PTH level. And if you've been a very long term, like 10, 20, 30 years, you know, sometimes, you know, elevated creatinine, which is indicative of kidney dysfunction, obviously that's not good. If you do have a high corrected calcium but low PTH, people will get confused. I mean, I think we see this sometimes in the groups. we really don't know. That could be either you're taking excessive amounts of calcium supplements, but you are hypopara, or it could be that your PTH is suppressed by the high calcium levels and you're not truly hypopara. And this happens sort of in that gray zone region. A lot of times, 6 to 12 months out from surgery, people can get confused if they've been so-called over-supplemented to some degree with calcium and they haven't really tried a wean yet. So, and then if you have elevated creatinine, like kidney dysfunction basically, then you do need that full BMP, the basic metabolic panel. If the BUN is high, like you have an elevated BUN to creatinine ratio, that could mean that the elevated creatinine is just simply due to dehydration. So then you should just kind of drink a lot of fluids and then get that rechecked actually. Another thing to keep in mind is if you have some chronic kidney disease, we call it the kidney dysfunction, that itself can cause high potassium and or high phosphate levels. So that requires, being followed by a nephrologist. If the potassium and or magnesium are low, those also need replacement. Like I mentioned, they're needed for calcium absorption and they can mimic hypocalcemic symptoms. So for vitamin D, there's kind of, to me, a little bit of a controversy even amongst different physicians, different patient advocacy groups. There's a lot of theories out there. What is the optimal level? In general, most patients would be considered sufficient, including hypopara patients. I think if U25-hydroxyvitamin D is greater than 30 nanogram per milliliter, this is the units for US, not for Europe, which is different. Some patients I do think seem to do better at 40 to 60. Especially patients with things like fibromyalgia, other autoimmune disease, patients that I see myself, I sometimes try to keep them a little bit higher on the vitamin D. Then, like I mentioned, like the 25-hydroxyvitamin D level itself is important for immune functions, not only bone health, and it's also important for, muscle symptoms. Like low vitamin D itself, regardless of whether you have hypopara, will cause patients to feel weak, heavy muscles, cramping muscles, etc. Now, the 125-dihydroxyvitamin D, that's the activated form of vitamin D, like I mentioned. That is what calcitriol is 125-OH2D. And this, so basically PTH is needed to convert 25-hydroxyvitamin D to the 125-dihydroxyvitamin D. And the lab test for 125-dihydroxyvitamin D, if you're on calcitriol, it may simply reflect the adequacy of that dose. It's not going to differentiate between your own body's activated vitamin D versus a calcitriol. So, and then it can be very variable depending on the timing and the dose of the calcitriol. So it's not often checked regularly in medical practice, but I think sort of intermittently, maybe once a year or two, like it might be useful to just check if you're on calcitriol and there seems to be some issues with why are you not having success with keeping things stable, that might be something to check. But again, you have to be consistent when you check it relative to your calcitriol dose. So we talked a little about potassium before. So potassium can go low, especially if you're on hydrochlorothiazide. So HCTZ is a blood pressure medication that's used in hypopara when 24-hour urine calcium is too high, because it can help reduce urinary calcium excretion. In normal people even, a potential side effect of hydrochlorothiazide is actually high calcium, so it kind of raises serum calcium, decreases urinary calcium. However, it also can cause the low potassium and then low blood pressure, low sodium sometimes, low magnesium even, high uric acid, which increases the risk of gout. So I'm actually on hydrochlorothiazide myself, and my potassium is low frequently. I'm on the triamterene, the diazide, which is combined with hydrochlorothiazide, which is a K-sparing diuretic. So there are ways to sort of help with that, and then of course just taking potassium supplements would be another way. The 24-hour urine calcium test is extremely important. Surprisingly, it often seems to be forgotten about by some physicians out there, it sounds like. It's very important to monitor regularly. If you've never done it before, you should definitely ask for it. Even like if you have symptoms and your calcium levels are at goal, you need to have this test so you know kind of how to discuss your goal levels. The reference ranges can vary by labs, but I think this was talked about in a different talk during this conference. I would say in general you want to kind of keep the level less than 300. I think it's a little bit lower for females than males, but that's a general ballpark that you want to keep it less than. And then in certain situations like hypomagnesemia, sometimes checking urine mag may also be helpful. So what if your 24-hour urine calcium is persistently high or you're already getting kidney stones? You need to check this litholingual 24-hour urine supersaturation analysis because it helps kind of figure out what kind of stones are you making, what are you at. There are different like citrate and other things that can contribute to kind of stone formation. And my twin sister is a nephrologist, so if anyone has questions, she can always answer some questions after this about it. But basically, you know, a nephrologist should really be involved to order and interpret these 24-hour urine supersaturation tests. Generally, you should be keeping well hydrated, drink 2 to 2.5 liters of fluid a day. Your urine should always be light yellow in color. Should have renal imaging, something like either the CT scan or at least a renal ultrasound, maybe every 5 years if you're asymptomatic, and more frequently, I'd say at least yearly or so, if you have actual active kidney stones. And then you really should discuss management options, of course, with your own doctor. Same with if you already have kidney dysfunction, you should be following with a kidney specialist and nephrologist. They will want that urine protein to creatinine ratio, like I mentioned, sort of determines how severe that kidney dysfunction is, and they can help manage your diet and other things that can help with the kidney failure. So a little bit about, you know, how do you talk about all these labs with your doctor? Because it does seem that there's a lot of different experience levels of the endocrinologist with hypopara, including my own experience with my initial endo locally compared to the endo I see now, who's one of the medical advisors for this association. So, you know, there's different levels of medical language amongst doctors too, in terms of how they talk to you, different practice styles. Some are very rigid versus others will engage your patient preferences more. Main thing is like, don't be afraid to ask questions, and, you know, you could consider a second or third opinions if needed. I'd caution that you try not to give up too quickly, because doctor shopping has its own issues, but if you've gone, you know, at least 2 or 3 visits with a doctor who just absolutely seems to not be willing to engage with you with your hypopara, not taking it seriously with you, then it's time to consider as someone who knows a little more about it. So the main thing I wanted to say about this is that you should establish kind of what's ideal versus acceptable goal calcium levels for you. And this can take time. It's kind of like a work in progress most of the time. It can take probably at least 6 to 12 months to really figure out what that is. But off the bat, you know, at least from a post-surgical hypopara patient standpoint, I know most endos would just say, you know, you want to keep it 8 to 8.5 for your calcium. And, you know, the mildly low or low normal range, that's where you want to be. So when I was there, I was, quote, perfect. My calcium was, quote, fine. That's where they want me. And of course, I was having a lot of symptoms still. And the main thing is like, well, if your 24-hour urine calcium level is already less than 300 milligrams at that level and you just feel awful, you really should consider asking whether your goal level could be raised a little, because, you know, the main thing to keep it there is because they're trying to help prevent your kidney from damage. So, and versus, you know, if your 24-hour urine calcium is above 300 milligrams already at that time, then you need to be able to have that discussion. But weighing the risk of the kidney long-term versus your own sort of quality of life on a day-to-day basis, and you need someone who's going to support you and take care of you really in both sort of both realms, and not just following numbers as it seems. I do think that a fair number of hypopara patients will feel better, or do feel better at calcium levels that are higher than 8 to 8.5.
Dr. Liang?
Yes?
We have about 10 minutes left, but I have several questions.
Oh, okay.
Okay.
Should I answer them now, or just, I think I have about 5-10 minutes.
Yeah, go ahead with this slide and then we'll answer, because I think this is kind of important.
Okay. So for post-op surgical patients, I would ask what your pre-op calcium level was if it was checked, because I think comparing it can be very helpful. And then, of course, always tell your doctor about your symptoms even before you discuss with lab work, because that's really important. Notice that hypercalcemic symptoms overlap a lot with hypocalcemia in terms of brain fog, muscle weakness, and fatigue, but it also has like nausea, vomiting, constipation, and thirst, which are a little bit different than the typical hypocalcemic symptoms. And you should always kind of ask your doctor, you know, is it okay to take extra calcium supplements or even extra calcitriol doses for certain situations, either stressors, etc. I had my initial doctor say you just never should, and it was kind of really ironic because I think that's the main thing, is that we have to adjust how much we take depending on stressors. And then you should also consider, of course, PTH replacement therapies, Natpara when it was available, or Forteo now, off-label if you're too unstable or refractory to standard therapy. Always observe what kind of triggers seem to cause you more symptoms, and, you know, like I said, see if you can take some extra. Should I answer questions, or this is?
Yes, please.
Yeah.
Okay, the first question is there any connection between hypopara and the onset of PMR, polymyalgia rheumatica?
I would say no. Polymyalgia rheumatica is a different autoimmune disorder that affects elderly patients. It has its own autoimmune kind of genetic predispositions to develop that. It's characterized by sort of shoulder and hip girdle pain and stiffness, and elevated inflammatory markers, which the elevated inflammatory markers, that's not something that specifically is, you know, due to hypopara.
Okay, thank you. And then someone asks, is there a specific lab test to check out gut, I believe, stomach issues? And if so, what test should we ask for that?
Like in terms of having gut symptoms or gut issues? I mean, I don't think so. Sometimes, like, there is some thought, I looked it up because I have my own gut issues with hypopara. There is some thought that could, the low calcium cause something like sort of exocrine pancreatic insufficiency. So, I mean, it may not be a bad idea to check amylase and lipase, which are pancreatic enzymes, but I don't think that's well established as a standard thing to check.
Okay. And one person said, I'm 14 years post-surgical. I've never had PTH levels. Is there any point in that now? I would assume getting them tested. Yes,
I would, because again, I mean, to just really solidify the diagnosis and to see whether it's consistent, you know, even if it's been a long time, it just, even for insurance purposes to some degree, it's important to have a firm diagnosis that makes sense with the labs. So easy to do. It's just a lab test.
Okay. And what about GFR tests? Should we be concerned if they're low?
Yes. So that's actually that's always reported out automatically along with the creatinine, the eGFR, which is estimated glomerular filtration rate. So they'll automatically calculate that along with the creatinine. I would say, you know, with the eGFR, if it's just mildly low, it's probably not, you know, something to go too crazy about, but probably just to be followed carefully, because the creatinine is probably the one that, you know, is a little bit more followed closely, you know. Like if it's going to progress, the creatinine will go up. Can you comment on that?
Yeah, I can comment on that. I'm Kim's sister, Kelly.
Hi, Kim.
Pretty much you'll always get a GFR readout at any time you have a creatinine check because they're related. The GFR is just a calculation that's based on the creatinine and your age and your sex and everything. So the higher the creatinine, the lower the GFR. And we generally don't get too concerned until the GFR is less than 60. That is when we call it like stage 3 chronic kidney disease, is when it drops less than 60, anywhere between like a GFR of 30 to 60. Anywhere between 15 to 30 for a GFR is considered stage 4 chronic kidney disease. And then we don't really worry about needing dialysis until it drops well below 15. So you might want to discuss this with your doctor about, you know, the GFR, but it generally does correlate very closely with creatinine.
Okay.
Okay, thank you, Dr. Liang. Okay, and what about the half-life of calcitriol? How long does calcitriol stay in your body?
I think they usually say something about 8 to 12 hours. Like that's why they do say if you have to take it like a certain amount, it would be best to split it into twice a day because it doesn't last a full 24 hours. But, you know, sometimes if you only need it once a day, then, you know, usually taking in the morning makes sense.
Okay. And my endo never checks my phosphorus, but he does a BMP every 1 to 2 weeks and checks my vitamin D every 2 weeks as well. He also says my urine calcium is not necessary because he watches my GFR creatinine very closely with the BMT. Does that seem right?
Kind of, but in hypopara, the phosphorus is very important to monitor as well. And phosphorus, like I said, is not included with the BMP. So, I mean, the BMP is, I mean, that's good, but you're sort of missing that one piece of information that, because again, remember we said the calcium biphosphate product is something we specifically with hypopara need to worry about and make sure that that stays less than 55. And in hypopara in particular, our phosphorus levels would tend to be high.
It might be better for your doctor to follow a renal function panel because that includes both that calcium, phosphorus, and albumin, just for ease of
depending on your, I think it depends on your clinic, and if they're able to order a renal function panel, that would include that. But yeah,
my doctor always does renal function as well. Okay, and you may have explained this and someone missed it, but can you explain why we need the calcium adjusted with albumin?
Yeah, it's about because the calcium will bind to albumin, which is a protein in the body that, you know, basically when the calcium is bound to the albumin, that calcium is not available for the tissues and nerve and muscle function, all of the different bodily functions, the tissues and everything. That calcium is just like, you know, bound to the albumin. So it's again, it's going to be spuriously like looking higher than it really is if your albumin is over 4.0. And vice versa if the albumin is low.
Okay. And is free T3 related to calcium hematosis and went on T4 because I had more low calcium?
No, so I was going to talk about the thyroid here where, you know, basically, you know, these are thyroid functions. So free T3 and free T4 are basically thyroid function markers. They should be measured in conjunction with TSH because TSH is the most sensitive thyroid function marker. If the TSH is high, then you're hypothyroid. If your TSH is low, then you're hyperthyroid. You should expect the free T4 and or free T3 to be high when the TSH is low. That would suggest hyperthyroid and vice versa, like they're opposite. So if that makes sense. We don't really know whether it sort of plays in directly with hypopara or Hypopara symptoms. It doesn't directly affect the calcium or the hypopara, you know, lab levels, but to me there is a question whether if you're hyperthyroid, say for instance, and your heart is racing a lot, that could theoretically make you, you know, make you become more hypocalcemic just because of the muscle, you know, muscle function there. So but these are all theoretical. I don't think it's very well described.
Okay. My son, he's 8 years old, has 24-hour urine creatinine is very low, and the doctor never gives me an explanation of what this means.
24-hour urine creatinine?
Yes, it's very low. The doctor never explains it.
Yeah. Do you want to check? I don't know.
Did you say the 24-hour urine calcium or creatinine?
Creatinine.
Creatinine.
Oh. Sometimes when the 24-hour urine creatinine is low, that means it's like an undercollection. We oftentimes use that to see whether it's a full collection. Alternatively, it might mean that that there's just not that much muscle mass or not that much protein that you're ingesting. But generally, if it's low, it means that maybe it was an undercollection.
Yeah, like maybe didn't get the full 24-hour, all of the urine in the 24 hours weren't fully collected.
Mm-hmm. Okay, and we're at one minute, so I have one comment. My post-surgical course was very similar to yours, including my surgeon telling me that my hypopara was likely transit. Thank you for sharing your story and for all of your suggestions.
Sure, and glad to have been able to share it. So
okay.
If anyone has other questions, feel free to just reach out to me.
All right, and thank you, Dr. Liang, and thank Dr. Liang, your sister, as well, for joining us in. It's always a pleasure to see you all. And if we have any other questions, we'll just send them to you to answer.
Okay. All right. Thank you so much.
Okay, thank you.
Yep, bye.
Bye.